30ค่ะ
30แล้วได้ยินเสียงอาจารย์ชัดเจนดีไหมคะ
ชัดเจนค่ะอาจารย์
งั้นเดี๋ยวรอเพื่อนสักครู่หนึ่งนะคะ ได้แฮนด์เอาท์เรียบร้อยนะคะ Okay, I think we better start now. So my subject today is ulcerative and vesiculobular lesions, and I expect that all of you have already learned about red and white lesion and any kind of lesions already. So today we will focus only on lesions represented as ulcers, vesicles, and bullae. And from this topic, what can I move this slide? After this lecture, which will be about three hours, all the students should be able to explain about the lesions, including ulcers, vesicle, and bullae. And apart from that, if you see patients with this type of lesions, you should be able to take the history necessary for including all the information that you need to group all this history into the tentative diagnosis. And with the tentative diagnosis, which will you know about each disease, you should be able to explain the cause of each disease, the clinical features, and proper treatment. So, focusing on the diseases causing ulcer, vesicle, and bullae. And for the handout, you may see in the ebook or maybe the newer edition, but this edition, the 12th edition, is free of charge and you can download from the website. In order to identify the oral lesions, because the structure of skin and oral mucosa is very similar. So the basic of term of lesions, we use the same as the dermatological lesions. For macules, papules, all these are terms that we will use to describe lesions in the oral cavity. And because of many diseases in this group, patients may have also skin lesions. So all these terms can be used to describe the lesions of the patients, whether in the oral cavity or on the skin. So today we will focus on vesicle bullae. And you know that in the oral cavity, normally vesicle and bullae break easily, very rapidly, to be ulcers or erosions. But some ulcers may not have vesicles or bullae formation before developing into ulcers, and you need to notice about that, what type of disease that may have vesicles proceeding before ulcers develop, or some disease may have just only ulcer formation without the stage of vesicle or bullae. And the other type is the atrophy. Atrophy means the thinning of the epithelium. So the color will be quite red compared to the surrounding tissue. And also crust. We will not see crust in the oral cavity because of the moisture by the saliva. But at the vermilion border, because of the dryness, the crust formation can be seen on the lips or the area of the vermilion border. And this is, you can see the well circumscribed lesions. Just only the color is changed from the surrounding. So I will revise quickly on this type of lesions. We call it macule because sometimes other type of lesions can also be seen accompanying ulcer, erosions, vesicle and bullae formation in some diseases that we are going to talk about. And then this type of lesion, you can see the heart rate lesion, quite small size. The diameter is less than 1 centimeter. So with this, no fluid content. This type we will call papule. So you don't need to describe what I just said. We just said that white papules were at the right buccal mucosa. So with this term, like macules or papules, it's easier for our clinicians to describe lesions, and we can understand each other very quickly. And this is called plaque. Plaque is very similar to papule, but the size is larger. So if the lesion is larger than 1 centimeter, we will consider that as plaque. And the plaque even is raised lesion, but normally it's quite flat. And this type is different, called nose. The lesion is quite deep, if on the skin or in the lamina propria. And this is called pustules. If the content is pus, we will call pustule. And the pustule is very similar to vesicle. Vesicle will have clear fluid inside, but if with the pustule, the lesion contains purulent material. And this is vesicle. You can see the fluid inside is clear fluid. And vesicles can occur as a crop like this. So many small vesicles develop on this area. And this is called bulla or bulle. You can see the size is larger. In some textbooks, may consider 1 centimeter to differentiate between vesicle and bulla. Like some textbooks may use 5 millimeters. So it depends, but actually vesicle is small blister, but if it's larger, we will call bulla or bulle. And this is a kind of atrophy. You can see the normal area of the gingiva is quite pale pink, but the area with the atrophy, which means the thinning of the epithelium, you can see the reflection of the blood vessel coming out. So it's more red on this area. This is called atrophy. And this type we call erosion. Sometimes if vesicle or bulla formation is very shallow in the epithelium area only. And after the rupture, losing of the epithelium but not involve the connective tissue yet. So it means that the lesion is quite shallow. It means we can call it erosion. So not the whole part of epithelium was lost. This is very shallow one. Sometimes the patient may not feel painful at all with the erosion type. So different from the ulcers. For ulcers, the lesion is deeper because loss of all the epithelium. This one you can see almost a sheet of epithelium desquamated from the lamina propria or connective tissue layer. So this kind we call desquamation. This is ulcer that I just mentioned. You can see the loss of all the epithelium and also involving the lamina propria of connective tissue part. So the lesion is deeper than erosion. In the oral cavity, what you can see, the base is yellowish. And if it's inflamed, you can see the red margin around the ulcer. This is also the ulcer formation. The base is yellowish, and with the inflammation, you can see red margin. And this type can also be seen in the oral cavity or at the angle of the mouth. This is called fissure. And the slab. The slab is the dead part of the epithelium. So sometimes with the chemical burn, because of the death of all the epithelium, you can see whitish lesion like this that can be scraped off. Sometimes the underlying tissue is bleeding. This type of lesion we call slab. So with this, you need to ask the patient about the history, maybe burning from hot food, or sometimes with the chemical, like some medication or tablets that the patient put inside the oral cavity because of that toothache. And what is this? You can see this is the yellowish fibrin covered deep ulcer. So we call this as pseudomembrane. Sometimes you can see something like this. With the deep ulcers, pseudomembrane may cover the surface. And if you remove the pseudomembrane, you may see the base with the bleeding. And this is the crust. Crust can be formed on dry area. And if the ulcer is very deep and with the bleeding, the crust will be very dark. We call the hemorrhagic crust. So in order to be able to diagnose patients with lesions presenting as ulcer, vesicle, and bullae, you need to ask about the duration of the lesions. Apart from that, any history of similar lesions in the past, some patients may recall and tell you that they experienced this type of lesions before, maybe at different location in the oral cavity or perioral area. So with the history can help you identify or diagnose the disease. Also, number of lesions, if occurred in the past, how many, and at this time, how many lesions that occur. So with all these three subjects that you ask the patient, you can group it for the duration in this group of diseases. If the lesions occur for more than 3 weeks, we will classify it as chronic lesions, otherwise acute lesions. So I mean the lesions representing as vesicle, bullae, and ulcers. You need to ask about that. And also the history of similar lesions. If the patient has history of similar lesions, that should be recurrent disease. But if no history, you can classify as primary disease. And the number of lesions, just only single or multiple lesions. Because with this, you can have it in the clinic with the history and clinical presentation. With all this information, we can classify or grouping the disease that causing ulcerative and vesiculobullous lesion into this group. The first group, disease is causing acute, multiple oral ulcerative and vesiculobullous lesions. You can see that the difference between each group, acute or chronic, can classify into this group. But the different and all this with the multiple lesions, acute presenting less than 3 weeks, more than 3 weeks, and if they are multiple. But if the history of recurrent, whether presenting with single or multiple, it will be grouped in this group, the recurring oral or perioral ulcers. But if it's causing single ulcer, can be acute or chronic, but just only single and no history of recurring, we will group it into single oral ulcers. So if you find patients with a lot of ulcer in the oral cavity presenting for more than 3 weeks, you should be able to diagnose. It should be in this group. If single ulcer never occurred in the past, so it should be in this group, single oral ulcer. But if this is the first time that the patient experiences this type of lesions and it occurs for just only a few days, so so many areas affected. So this should be in the first group. What I'm going to describe to you later on will be all diseases that are quite common or necessary for you to know in each group of these. For the first group, acute ได้ยินไหมคะ Any questions?
เพื่อนน่าจะไปโดนเฉยๆค่ะอาจารย์
Okay. So now I'm talking. Any question you can ask anytime, okay? Now we are going to talk about the first group, the lesions that occur as multiple area and with the acute formation. In this group, it can be viral infection. This is very common cause of acute multiple lesions in the oral cavity. So you should know quite well about this group. Apart from that, erythema multiforme, or sometimes we call briefly as EM. Plasma cell stomatitis and oral hypersensitivity reactions, and necrotizing ulcerative gingivitis or not. Now talking about viral infections. Three viruses that normally cause oral lesions. They are herpes simplex virus infection, Coxsackie virus infection, and varicella zoster virus infections. You can see from this that all these are herpes virus that can cause diseases in humans. We are going to talk about this herpes simplex virus type 1, type 2, and varicella zoster virus. Or you may call, it can also be called human herpes virus 3, but the more common, the more term used is varicella zoster virus. Other herpes virus like cytomegalovirus, Epstein-Barr virus, human herpes virus type 6, 7, and 8 can also cause oral lesions, but because it's not in this group, so I'm not going to talk about in detail about all other herpes viruses. Now talking about herpes simplex virus type 1 and type 2, or HSV1 and HSV2. Both of them can cause primary, primary, can cause acute lesions and recurrent. So this is different group. You can see not the same group. So both type of herpes simplex virus can cause both primary and recurrent herpes simplex virus infection. For varicella zoster virus, there are also herpes virus. Varicella zoster virus can cause varicella, which is this is the primary infection, and recurrent or secondary are herpes zoster. You should know a little bit about herpes virus because they have quite unique characteristics like double-stranded DNA, and after primary infection, it remains latent in the nuclei of specific body cell for life of the infected individual. And for herpes simplex virus type 1, type 2, and varicella zoster virus, after primary infection, they can remain in the sensory nerve ganglion. It means that in that case can also be in the trigeminal ganglion. And means that after this herpes virus enter into the cell, enter into our keratinocyte with the endocytosis, it can induce replication in the cell, and after that, the cell break down, and the viral particle can infect other keratinocytes. At the same time, the virus can also penetrate into the neuron, and that latent virus can be in the nuclei for life of that person. And if the latent virus be activated, they can cause replication again, and the virus will travel along the nerve to infect the epithelium or epidermis, causing the lesion. And the reactivation can be both symptomatic and asymptomatic. So it means that sometimes without any lesion, replication occur and can cause shedding of the virus, maybe in the oral cavity if it remains latent in the trigeminal ganglion. And sometimes with the lesions occur in the oral and perioral. And with that, the virus can be transmitted from host to host. Means that if you use the same utensil, contact with the saliva, or the virus can also, if infected the genital organ with the genital secretion, can also the source of the virus that can infect it. I'm not to talk in detail about this. It means that herpes simplex virus type 1 and 2 are very similar. And if you would like to identify, you can use the enzyme restriction endonuclease to analyze. But what important is that herpes simplex virus type 1 normally will infect for the upper part of the body, like central nervous system, oral, pharyngeal, eye, or, and sometimes finger of dentists or other healthcare worker if the cross contamination occur. And herpes simplex virus type 2 normally at the genital area. But actually both herpes simplex virus type 1 and type 2 can infect both areas, genital and oral cavity. And the incidence of herpes simplex virus infection in the past quite a lot for baby after 6 months of age. So it means that antibody from the mother disappear already. And the peak is about age of 2 and 3. But later on, the infection can also occur in older children, in young adults, in adolescents. So it means that not just only in children that you can see primary herpes simplex virus infection. This is I talked about already. And one important thing, like concurrent primary infection of both areas have been reported. So it means that for herpes simplex virus, it can cause primary infection at many organs at the same time or at the different times. So it means that it's quite contagious that if the virus shedding occur at any area, the patient himself need to be aware of and try not to infect other area of the body, even with the eye or any other part of the body. For herpes simplex virus, either type 1 or type 2 can cause primary herpetic gingivostomatitis or primary herpes, or we can also call primary herpes simplex virus infection. And most of these type of infection are subclinical. More than 90% are subclinical. cause pharyngitis, similar to upper respiratory viral infection, but about 1% that can cause symptomatic primary herpes simplex virus infection. And with this type, normally we as a dentist can see patients with symptomatic primary herpes simplex virus infection. The patients may be children, adolescent, or young adult, or even quite the elderly if never contact with the virus before. And this is the example of primary herpes simplex virus infection or primary herpetic gingival stomatitis in a children. You can see the very inflamed gums, red and edematous, and also bulla formation. And this is an example of oral lesions. What type of lesion is this? Can anyone tell me? What type of lesion is it? Are you
เป็น
all
อั
with
ล
me?
เป็นอัลเซอร์
Ulcer.
เหรอคะ
Yeah. What type of ulcer? Multiple, right? Multiple ulcers. And if you try to see, you can see, I will point out this one. Can you see this one? Single small ulcer, right? Round ulcer. And you can see something like this in some area. And with the large irregular lesions, something like that. So it means that what you have to notice is that if small round ulcer like that, normally it caused by breaking down of small vesicle. And with the infection can cause inflammation, the margin is red. So you can see that this creates small ulcers like that. But if they occur as a crop of vesicles, so sometimes after breaking down of small vesicles, the ulcers, small ulcers can coalesce to form large irregular lesions like that. You can see. So if you see large irregular lesions like this, try to find out all those small discrete ulcers at the surrounding area. So it will be easier to diagnose because for the herpes simplex virus infection, they will cause vesicle formation, can be anywhere in the oral cavity. And then with that vesicle, they break down easily and rapidly to form ulcers like that. So this is the typical of primary herpetic gingival stomatitis. You can see with the name of the disease, primary occur at first time, no history. Herpetic, caused by herpes simplex virus infection. Gingival stomatitis, inflammation in the oral cavity because of ulcer, and also inflammation of the gingiva. That is the generalized marginal gingivitis, but sometimes localized marginal gingivitis can also be noticed. With this, you can see that the patients affected by primary herpetic gingival stomatitis, they will have, if you ask the history, fever, nausea for a few days before the lesions develop. And what type of lesions occur? At first, vesicle formation first. And then after that, breaking down to ulcers and with the gingival involvement. You can see quite clear here. Small round ulcers develop on dorsum of tongue. So it means the keratinized mucosa can also be affected. Small round ulcers, some area with the erythema. And also here, red inflamed gingiva, regular lesions with round ulceration. So with the history of generalized symptoms, fever for a few days, maybe nausea and lymphadenopathy, cervical lymphadenopathy also can be noticed if you try to palpate the lymph node of the patients and with the lesions. So normally can be clinically diagnosed. This is an adult about 30 years of age, complaining about painful in the oral cavities. And when you can see some marginal gingivitis on some area of the patients. And what about the ulcer? Can you notice what I just mentioned? Can anyone explain about the lesions here? Is it similar to the previous case? Anyone? Or I can ask any name.
เป็น large irregular ulcer หรือเปล่าคะ
Yeah, you can see large irregular ulcer, but large irregular ulcer, is it easier to diagnose whether this is viral infection, whether this is herpes simplex virus infection? What can help more? What type of lesions? What is the cause of large irregular ulcer? What is it? Let me ask. Ron Pong. Is that correct? Ron Pong. Ron Pong, can you answer my question?
ครับอาจารย์
Okay, I can.
It's unilateral. I don't know actually, but I know that if it's unilateral, it's mostly the herpes virus, right?
So be that some like what is the typical of ulcer sigma vesicle breakdown? If vesicle, small vesicle breaking down, so do you agree that do you agree that the small ulcer like that can help us?
So it's the aggregation of small round vesicles, right?
Yeah. 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 Thank you ทุกคนผม
ขอบคุณครับ
ค่ะ That
อาจารย์คะ
ค่ะ
พอดีเมื่อกี้
โอเค
ไม่ได้ยินเลยค่ะ ขออีกรอบหนึ่งได้ไหมคะ
ไม่ได้ยินไม่โอเคค่ะ you cannot hear me at กอนพง right? Okay,
ใช่
I will
ค่ะ
explain you that กอนพง said the coalescence of the small ulcers can cause large irregular lesions like this, large irregular lesions. But what we can notice is that the coalesce of small ulcer occur after the small ulcers occur. And what is the cause of small ulcer? Breaking down of vesicle. So you think about the small vesicle after breaking down can cause something like this. Small round ulcer with red margin. So if you try to notice small round ulcers surrounding the large irregular ulcer, it means that the most likely is the large irregular ulcer occur from coalesce of small ulcer like that occur in crops. So it means that the vesicle formation occur before ulcer present in the oral cavity. So what is the cause of vesicle formation? Normally because of viral infection. And the most common viral infection is the herpes simplex virus, type 1 or type 2 in the oral cavity. So with the clinical presentation like this, together with the marginal gingivitis and history of fever about a few days before developing all these lesions, you should be able to diagnose this is the primary herpetic gingival stomatitis, most likely caused by herpes simplex virus type 1 and type 2. Okay? And this is also very similar lesions in different patients. Large irregular lesion like that and small round ulcer. This is also very similar. I showed you this slide before. And marginal gingivitis, you can observe. So if we try to look what happened in this disease, fever, malaise, sometimes with a headache, a few days, and later on vesicle on oral mucosa in general can be anywhere in the oral cavity. And then breaking down of the ulcer, small, round, shallow ulcer, yellowish base, and red margin develop with cervical lymphadenopathy and gingivitis. Normally, with the history and clinical presentation, we can make diagnosis. But if you would like to confirm the diagnosis, what we can do is the viral culture. Isolation of herpes simplex virus by smear from the intact vesicle. Normally, it's very difficult to find intact vesicles from this disease. But if you can luckily find one, you have to open the vesicle and from the base, take the tissue from that and send for viral culture. It may take maybe at least 1 week to know the result. Or you can smear from the lesions and send for immunohistochemical technique using monoclonal antibody to see whether it's the herpes simplex virus infection. And the other thing is that the serology, if you take the serum, the blood sample from the patient, first time within the first 3 days of the infection, and maybe about 1 month later on. And the result is the at least fourfold rise in the antibody titer to herpes simplex virus that can confirm about the herpes simplex virus infection. But actually, because it takes at least 1 month to know about the result of the serology. And normally the lesion will disappear after about 2 weeks. So it's no help diagnose this disease just to confirm the herpes simplex virus infection. So normally serology technique is used before organ or tissue transplant because the patients with antibody to herpes simplex virus tend to have recurrent lesions once they have like immunosuppressive drug or if they have low immunity. So in that case, if the patient is positive to herpes simplex virus, the physician normally will give like antiviral to prevent recurrent infection of herpes simplex virus because if it occurs, it will cause like very difficult to treat and causing chronic lesions. So it's better to suppress to prevent the recurrent lesions from herpes simplex virus. And this is one of our occupational hazard. It means that during patient having all those lesions in the oral cavity or after the latent and reactivation of the virus without any lesions, but the saliva contain the shedding of the virus. And if even wearing gloves, but what about breaking of the gloves and you have ulcers or any scratch on your fingers, you can get herpes simplex virus infection of the skin or fingers like that. And primary infection, like erythema, edema, and very painful with the vesiculation develop. And after healing, it can occur with a recurrence of the lesion for life. So this is occupational hazard, and it means that if you see patients with herpetic infection, either primary or recurrent, you should not treat the patients. You should postpone the appointment for at least 2 weeks. And apart from that, even the patients themselves can also have infection because like other infection, like eye infection from the spreading of the saliva with the virus that already in the clinic. So for the sake of the patients, the sake of all the healthcare workers looking after the patients, you need to postpone the treatment and you need to tell the patient how to control the contamination to other persons in their families or friends not to contact and get infected with what they have because all these patients seems to be like reservoir of the herpes simplex virus. And this is the type of herpetic vesicle. You can see why the ulcer is quite shallow because it's intraepithelial vesicle. And the smear, you can see the multinucleated giant cell and ballooning regeneration of the nucleus. For the treatment, it depends on severity and stage of the symptom. Normally, if you are going to give the systemic antiviral, you should give at the very early stage, not longer than 72 hours, not longer than 3 days after the infection. Otherwise, it cannot help because like the severe stage already passed. And if it's not so severe, you don't need to give systemic antiviral like systemic acyclovir. But if the lesion is very extensive, systemic acyclovir can help the patient. So it means that if the patient is immunocompromised, it's quite necessary to give systemic antiviral. And to reduce secondary infection, you can also prescribe antiseptic mouthwash. I talked about herpes simplex virus infection already, type 1 and type 2, similar appearance in the oral cavity. Now we are going to move to Coxsackie virus infection. you can see for Coxsackie virus infection can cause lesion like that. So normally, this disease we call herpangina. Herpangina can cause vesicle formation, normally affect the posterior part at the back of the oral cavity. After the vesicles develop, it also breaking down easily to form ulcers. So you can see it normally occur at south palate, jugular, fasciocular at the back, causing dysphagia and can also cause systemic symptoms like fever, and the most common is the Coxsackie virus group A, common cause of herpangina, mostly type A4. Herpangina normally occur in children, malaise and fever, and also sore throat. After that, the vesicles develop. This is a self-limiting disease, and because occur in children with the fever and sore throat, dentists not see this type of patient so often. Maybe just only pediatrics, yeah. This is also herpangina, so the severity is different in each patient. And with different strain of Coxsackie virus, the patient can get herpangina many times during their childhood. Another disease caused by Coxsackie virus. You can see oral small round ulcer like that in the oral cavity in children. And this is a vesicle, macule and vesicle on their palm and on the feet. Vesicle, papule, they can cause macule, papule, vesicles on the skin, in the oral cavity, hand, and feet. So this is hand, foot, and mouth disease, usually caused by Coxsackie virus A16, but other strain can also cause. This is common in children also, but also affect young adults. And when it occurs in epidemics. So you can see the kindergarten closed because of hand, foot, and mouth disease, because this is very contagious. And vesicle develop at any area in the oral cavity, can be on the tongue, buccal mucosa, soft palate, and gingiva. But the most important is the skin involvement that can help you in diagnosis of this disease. So with the oral lesion, you need to try to vet and see whether the patient's got other lesions on the fingers or their toes, can be red macule, papules, or small painful vesicles. And one more thing that you should know is that the strain enterovirus 71, you see why sometimes with the hand, foot, and mouth, normally other strain can cause self-limiting disease, no any complication. But if it's caused by the strain enterovirus 71, in Taiwan and also in Thailand, you can see that this type of Coxsackie virus can cause other complications like pneumonia or encephalitis, meningitis with high fever. So in that case, it means that some patients with hand, foot, and mouth if caused by enterovirus 71, need to have close monitoring, because if it's caused by enterovirus 71, the fever is very high and may cause other complication, very serious complication. And with the lesion in the children, adults or adolescents can also get infected with hand, foot, and to have hand, foot, and mouth later on. And the lesion occur in adolescents and adults are very similar, causing hand, foot, and mouth lesions. This is very similar to herpangina because other strains can also cause hand, foot, and mouth. So you can see that in children can have hand, foot, and mouth occur many times, or hand, foot, and mouth and herpangina occur many times during their childhood. This is like try to give more information again. After contacting the virus, about 3 to 6 days, and then the patients will have fever, malaise, sore throat, and after that, a few days, vesicular formation in the oral cavity, hand, foot, and mouth. So normally we can have clinical diagnosis. If necessary, you can have serology to confirm, but normally it's not necessary, and just only symptomatic treatment for fever and maybe like just anesthetic mouthwash or anesthetic mouth gel to reduce the painful caused by the ulcer. Acute lymphonodular pharyngitis. This is just to know about the name. Actually, it's a variant of herpangina and also caused by Coxsackie virus. And same distribution of the herpangina is mean that just only at the area of subpalate, uvula, and tonsil fossopilla. And what occurs is just only yellowish white nodule, not progress to vesicle or ulcer, and self-limiting, just supportive treatment. The lesion can disappear by itself. Yeah, this is the lesion that caused by Coxsackie virus. Area similar to herpangina. We call acute lymphonodular pharyngitis. Actually, this disease is quite rare. I have seen just only one case. And then the third type of common virus infection in the oral cavity caused by varicella zoster virus. This is also herpes virus, same as herpes simplex virus. Coxsackie virus is not herpes virus. Okay, herpes simplex virus, varicella zoster virus. So because it's a herpes virus, primary infection and secondary or recurrent infection. Varicella is the primary infection, and herpes zoster or shingles is the recurrent or secondary infection. Varicella. This can also cause oral lesions, vesicle, and ulcer, very similar to primary herpes simplex virus infection, but the most prominent lesions on the skin. So normally patients don't come to see us. They will see physician because of all those macles, papules, and vesicle on the skin, normally on the trunk. This is the oral lesions of varicella. What about all these small ones? Are they lesions? Anyone can tell me? Are they lesions small like this? What are they? Nattawalai. Can you tell me? Nattawalai ค่ะ What are they?
vesicle เหรอคะ
Vesicle is here. Vesicle is here only. But what about this? This is at, can all of you recognize what area is it? This is at labial, lower labial mucosa. And then we retract the lower labial mucosa out. You can see the vesicle here, the lesion of varicella. But what about all these small ones? Think about the anatomy of this area. What are they?
ไม่ทราบอะค่ะอาจารย์ เป็นแปบปูเหรอ
Actually, if you retract this lower labial mucosa, they are minor salivary glands. You see the structure. They are minor. All these they are minor salivary glands. But the vesicle is here. Okay. Therefore, all these small ones, they are not lesions. Just minor salivary gland, which will be very prominent when you retract this lower labial mucosa. So, in order to identify lesions, we need to know about the normal structure. Okay. This is also the example of lesions occur in varicella, very similar to primary herpes simplex virus infection. You can see the small round ulcers on the palate, on the tongue, labial mucosa, inflamed red margin. I got these slides because a dentist gave it to me. These are the pictures of her own son getting varicella, and because she a dentist, so she took all these pictures. So I asked whether it's all right to show to dental students, and she says it's fine. She's happy to have this presentation of her own children. And also, this is the varicella of her son. You can see the vesicle formation at the back. And this is with the medication already on some part. And some area also the crusting formation. So this is the primary infection of varicella zoster virus. And you remember, after primary infection, after getting varicella, the virus will remain in the specific body cell. So because this herpes, her varicella zoster virus and herpes simplex virus can be in sensory ganglia. So if infected in the oral cavity, the virus can be latented in trigeminal ganglia. Same of both herpes simplex virus and varicella zoster virus because they are the same. They are herpes virus. In the latent phase, the patients don't have any lesions at all, but with the reactivation can cause both recurrence of the lesion or sometimes asymptomatic reactivation, no lesions, but the virus shedding can occur in the oral cavity. So some factors can reactivate the virus from the latent stage to replicate and travel along the nerve distribution to the area supplied by the nerve, epithelial cell in the oral cavity or perioral cavity. You can see this is the reactivation of varicella zoster virus of the trigeminal ganglion involving the ophthalmic division of trigeminal ganglion. You can see the lesion just only half. This is just only the left side on the distribution of ophthalmic nerve. So imagine about if varicella zoster virus affect the second and third division of trigeminal nerve, can it cause oral lesions? Luckily that herpes zoster is not that common as the recurrence of herpes simplex virus infection that we will talk about it later on. Just only 0.3 to 0.5% that the virus can reactivate and causing herpes zoster. And normally these patients, they may they have immunosuppressed, maybe from elderly or maybe from any medication or from underlying disease like any malignancy. That's the reason why herpes zoster occur. And with the initial symptom, pain and tenderness, or sometimes paresthesia along the course of the affected nerve. So if the pain occur on the distribution of nerve just only one side, and then after that, the lesions develop about 3 to 5 days or 2 to 4 days. It's up to any textbook. But after a while, and then the vesicles develop just only unilateral along the distribution of the nerve. This is very important that can be diagnosed as herpes zoster. You can see what division affected. Second division of the trigeminal nerve, you can see both skin lesions and oral lesion. And oral lesion, large irregular lesions like that, and also small brown ulcer. And the lesion doesn't involve, not extend across the midline, just only on one side, at the skin and in the oral cavity. So this is the herpes zoster, reactivation of varicella zoster virus, affecting the second division of trigeminal nerve. And this is also a case of an elderly affected by herpes zoster. You can see the skin lesion just only on one side, and oral ulcers, and here on the palate. And it seems that it can also seems to get also Bell palsy. And here after the medication, you can see the heel of the skin lesion, heel of all the oral lesions. The patient is back to normal after the treatment. This is also the second division lesions of the herpes zoster. You can see just only midline, not across the midline. So very easy to diagnose if the patient's got both skin and oral lesions, just only one side along the distribution of the nerve. This patient, came to see me because of painful along all these teeth. Even with the restoration, but after the periapical film X-ray, we could not find any pathology of all these teeth. And then 3 days after I asked her to come back. You can see vesicle breaking to ulcer along this gingiva, attached gingiva, and also here inflamed marginal gingiva and erythema with ulceration, but no skin lesion. So in this case, it's very difficult to diagnose whether it's herpes zoster because actually herpes zoster affecting the second and third division of the trigeminal nerve may have just only one side, skin or oral cavity, or both skin and oral cavity. So for our responsibility, whenever the patients have oral lesions, with or without skin lesion, you should be able to diagnose whether it's herpes zoster because correct diagnosis will lead to correct treatment. And it seems like about 1/5 of herpes zoster cases affected either second or third division of trigeminal nerve. So what you should focus on is the unilateral facial lesion and also intraoral lesions along the affected nerve with the pain or paresthesia or tenderness as the initial symptom, and maybe 3 to 5 days later the lesion develop. So all these are very important. It's quite easy if the patient also have facial rash or skin lesion. It's not difficult to diagnose. What about laboratory testing? It's very similar to herpes simplex virus, to primary herpes simplex virus infection. You can do viral culture, cytology, and using monoclonal antibody. Because if you would like to differentiate between herpes simplex virus and varicella zoster virus, you can use different monoclonal antibody because with that they will have different antibody to varicella zoster virus or antibody to herpes simplex virus. And the most important is that herpes zoster can be life-threatening infection when immunocompromised patients are infected. And they have reports in the literature that herpes zoster can cause necrosis of alveolar bone and also exfoliation of teeth. So it depends on the severity of the disease and also the condition, the oral condition of individual patient. Because if the patient has like periodontitis, severe periodontitis, is quite susceptible to have like bone necrosis or exfoliation of teeth. So it depends because it also occurs that sometimes with the causing the non-vital of many teeth along the nerve affected by varicella zoster virus infection causing the herpes zoster. So you need to search on the literature about that. What about the treatment? What we expect for the treatment is try to shorten the duration of the disease and to prevent post-herpetic neuralgia. So you may heard about this term, but the post-herpetic neuralgia means that after the patient is getting herpes zoster, whether on the skin or in the oral cavity, they can also have this complication, post-herpetic neuralgia causing burning sensation along the area previously affected by herpes zoster. And we try to prevent that by giving antiviral therapy for patients with herpes zoster, and also try to prevent dissemination, especially in patients with immunocompromised condition. What we can give to the patient is the antiviral like acyclovir and other generation of acyclovir like wall acyclovir, all famciclovir, all these new generation, the patient doesn't have to take so frequently, but for acyclovir, they need to take like 800 milligrams 5 times per day for 7 days. So it's quite difficult for patients to take. So sometimes with other generation newer drug, less frequent taking of the medication. And to prevent post-herpetic neuralgia, it seems that for the elderly, sometimes we need to prescribe corticosteroid to prevent the nerve fibrosis. This is the antiviral therapy for herpes zoster. You can see the tray. Actually, acyclovir we can also buy from the Thai company is cheaper. You can see like valsiclovir just only 3 times per day, similar as famciclovir. It's quite safe to prescribe all these antiviral. Can you what you can see in this slide? Can you still remember what is the disease? Anyone can remember? What disease is it?
primary hepatic gingivostomatitis หรือเปล่าคะ
Okay, it's correct, very good. But what I would like you to notice is that if you see just lesion only on one side, do you doubt about whether it can be herpes zoster? Is it possible? Because sometimes with the primary herpes simplex virus infection or primary herpetic gingivostomatitis, maybe one side most affected, but what you need to differentiate from herpes zoster is that you can see marginal gingivitis affecting in generalized, not just only on one side. Okay, you can see on this area too. And apart from that, sometimes you can see other ulceration on the other side, which I did not show you in here. And the symptom is different. Fever can occur in both, but actually for the herpes zoster, mostly like interference of the sensation, like pain, tenderness, paresthesia along the nerve distribution before getting the lesions. But for here, herpes simplex virus infection, you can see fever, malaise, and then marginal gingivitis, a lesion all over the oral cavity, not just only in the area of nerve affected. These are different between these two. But sometimes if you see just only the slide, like maybe in the natural license examination, you need to notice more about the condition of the disease. What should be the correct diagnosis with all the information provided? Okay, we talked about viral infection already. Now let's move to the next disease, erythema multiforme. From the name, erythema means like red, inflammation, multiforme, many form, many types. You can see erythema, ulceration, is the crust formation affecting the vermilion border, also skin lesion. the target lesion here on the finger, ulceration on the tongue. So this is an acute inflammatory disease of the skin and mucous membrane. The lesion can occur on both skin and oral cavity. And in the oral, systemic condition and oral lesion occur at the same time. And is caused by immune complex and also related to cell-mediated immunity. Talking about what can trigger erythema multiforme, quite common that some medication like sulfonamide or carbamazepine and microorganism. The most common is herpes simplex virus infection and Mycoplasma pneumoniae. Some erythema multiforme may be idiopathic. It means that cannot identify the cause. So you need to ask the patient any medication taken recently or any infection like herpes simplex virus infection like herpes simplex infection 2 weeks ago or not, because some erythema multiforme may be related to herpes simplex virus. Normally, this erythema multiforme affects young adults, causing the bleeding, swelling, and crusting of lips. This is quite common lesion found in erythema multiforme and causing blood blister, causing hemorrhagic crust. Because the ulceration occur in erythema multiforme, they are quite deep. So bleeding occur, and once the bleeding occur on the vermilion border, getting crust, that is the hemorrhagic crust. And in the oral cavity, ill-defined ulceration is the irregular ulceration oral cavity. Maybe vesicle obula occur, but not typical as herpes simplex virus or varicella zoster virus. Round ulcer like that, not occur in the erythema multiforme. This is just only large irregular lesions. And the most important is also the target lesions on skin. The patient may also have ocular and genital lesions. You can see here, this is the case of quite severe erythema multiforme. If it's not so severe, maybe just only one oral mucosa, mostly oral mucosa affected. But if two or more mucous membrane affected, it's quite severe. It's called major erythema multiforme. But for Stevens-Johnson syndrome, you can see eye lesions, skin, oral cavity, and also genital lesions, and mostly caused by the drug, maybe carbamazepine or sulfonamide. This is quite severe and need to be admitted in the hospital. If my case, like just only in the oral cavity or at the vermilion border, just only supportive treatment or giving a topical anesthetic mouthwash or gel soft diet should be all right. But in case of moderate or severe, you may need to prescribe a short course of corticosteroid. My case can also prescribe with the topical corticosteroid. Now, let's move to the next one, plasma cell stomatitis and oral hypersensitivity reactions. This is like acute, talking about antigen antibody reaction first. Even with this heading, but actually for all these 6 items is related to antigen antibody reaction. can be acute onset, like erythema multiforme, or can be red and white reticular lesion or lichenoid hypersensitivity reaction. Fixed drug eruption is mean that with the systemic medication, the oral lesion can occur at the same location every time. And sometimes with that can cause plasma cell stomatitis. We will talk about in detail later on. Or can cause angioedema on the vermilion border. And apart from that, oral allergy syndrome, itching with and without swelling of the oral structure. This is a type of fixed drug eruption. See, with the medication, the patient will have ulceration on the tongue. Every time with this medication, we will call this fixed drug eruption. Now, talking about the plasma cell stomatitis, this is like is a sensitivity reaction to local antigen. May be related to any ingredient in the chewing gum or in toothpaste or mouthwash and causing the swelling and erythema of the gums. After the exposure, will prevent it will involve all the attached gingiva or also the alveolar mucosa. If you would like, let's see the clinical first. You can see the swelling, edema and erythema of the gingiva, both marginal and the whole attached gingiva in generalized, not similar to plaque-induced gingivitis or periodontitis. With this, if you would like to identify, actually it's most important how long the patients got it. Normally after exposed to allergen, which patient may not be able to identify, but you need to ask the history, any new toothpaste, new mouthwash, or any chewing gums. The patient may not notice that it may be related to chewing gums. And if you would like to identify, you need to do the patch test to identify the allergen. And in order to diagnose the plasma cell gingivitis, you need to do the biopsy. The biopsy of plasma cell gingivitis will show parakeratosis, epithelial hyperplasia, and actually the most important is the dense sheet of plasma cell in laminar propria. This is the significant finding for diagnosis of plasma cell gingivitis. If you can identify the cause, once the patient stop exposure to the ingredient, the lesion will disappear. In this case, it also seems to be like a kind of herbal ingredient that the patient exposed to, and when stop using, the lesion disappear.
อาจารย์คะ
ค่ะ
คือคอสมันมาได้จากหลายอันเหรอคะ หมายถึงว่าจากอินกรีเดียนอะไรก็ได้อย่างนี้เหรอคะ
It depends on individual patients. Maybe like ingredient in the what they say is like maybe ingredient in chewing gums, like preservative or taste, ingredient for taste of the chewing gums, which is different in each like some patients may be allergic to something which is different in individual. So it depends on each patient. So you need to find out that what should be the cause, but actually is from the history taking is very important. Something just recently used, never used before, or but for the delay type, if once you use it again after the first time, it will have the lesion develop. So it depends on individual. Sometimes like preservative in food or like coloring ingredient or taste ingredient, something like that. Order or taste ingredient. That's all that have been identified before. So it depends on different individual ค่ะ
ก็คือสมมุติอย่างคลินิก อันนี้หมายถึงว่าดูรูปอะค่ะ ก็คือดูว่ามันแบบมีการอักเสบอย่างนี้เหรอคะ ก็เลยเรียกว่าเป็น plasma cell stomatitis
No, from the from the clinical appearance, not just only red and edematous gum, but because it's not related to plaque-induced, it involves both marginal gingiva and all the whole attached gingiva internalized, and cannot identify any cause. So it seems to be from the clinical appearance, it seems to be plasma cell stomatitis because this is a typical clinical features of plasma cell gingivitis. But if you would like to be sure, you need to do the biopsy to confirm. So with the plasma cell infiltrate at the lamina propria, that we can identify that should be something because of like hypersensitivity of the patient to something, and then you need to identify what it is. If you don't know, you need to ask the patient to avoid something that might be related to. But if we can identify, it's easier for the patient to stop using that, and the lesion will resolve, and the patient get normal gingiva again. So for the clinical, you need to know that what is the clinical feature of each disease for the tentative diagnosis, and also the history, how long the patient has this type of lesion. โอเคไหม
โอเค
คะ
ค่ะ ขอบคุณค่ะ
And now we are going to talk about oral hypersensitivity reaction. Actually, plasma cell gingivitis is one type of oral hypersensitivity reaction. This is caused by delayed type hypersensitivity reaction to foreign antigens. And actually, for the dental treatment, we have so many type of dental materials that the patient may have oral hypersensitivity reaction to. And the lesions may have like so many appearance, edema, erythema, vesicles, or ulcers. So you can see here erythema at the labial mucosa, and you can see here the flange of a denture. So in this case, because of the free monomer, can cause erythema here because of the hypersensitivity reaction of this patient. Or formaldehyde can cause ulceration in these patients. Or eugenol because of the temporary filling at the posterior lower right posterior teeth, and the tongue, and with the saliva containing that eugenol can cause erythema at this side, the right side of the tongue. So it means that we need to find out what is the cause of this hypersensitivity reaction, which is different in individual patients. And here you can see the erythema along the vermilion border. So what can be the cause of this? Can be mouthwash, lipstick, toothpaste. So you need to ask, just recently changed of all these things. And also here, not dental stomatitis because of the candidal infection or because of the trauma, but because of the allergic to chrome cobalt can cause erythema at the dental barrier area. So what we can do to confirm is to do the patch test, because patch test for the dental material or other material, you can send the patient to the dermatology institute, which is quite near our faculty. So in that case, the physician can put the material, many type of dental material into the disc, aluminum disc we call fin chamber, and after that place on the back of the patient, the area with non-hairy skin, and keep it for 48 hours. After 48 hours, remove all those allergen, all those material, and see whether any reaction occur. So if it's positive, it means that the patient's allergic to that. And then they will have score the inflammation and give you the result. And after removal of those material, the patient will be asked to see after another 48 hours to see the allergic reaction. And we will have the report to make sure whether the patient is sensitive to that material, hypersensitive to that material or not. So in the mild case, just remove that allergen. But for the severe case, you can give topical corticosteroids. And this is very important in the case of like maybe allergic to the crown restoration or mercury, because mercury can cause lichenoid lesion, red and white lesion can occur. Mercury. So in that case, you need to change to other type of material. Or sometimes the patient is allergic to what I experience is allergic to the crown made by the gold thiosulfate. And then after that, the patient's got ulceration on the tongue contacting to this crown restoration. So after removal and put the temporary crown, the ulcer disappear. So it means that you need to change the material. So this is quite the indication to do the patch test. If you would like to change to the new crown restoration, you need to make sure that the patient is not allergic. The patient won't have hypersensitivity reaction to the new material because the crown restoration is quite expensive. So in that case, patch test to dental material is quite necessary. And when you know which one should be chosen from the report of the hypersensitivity reaction, so you can choose the correct material for the patient. Now let's move to the new disease. This is the NUC, necrotizing ulcerative gingivitis. There's some predisposing factor of NUC, like poor oral hygiene, heavy smoking, malnutrition, even with the infection with HIV or because of the stress. And what we have found in NUC is the proliferation of both fusobacteria and oral spirochete. And normally, NUC affects adult males. The destruction, like crater formation at the interdental papilla, is the characteristic of necrotizing ulcerative gingivitis or NUC. And sometimes after the crater-like lesion at the IDP, it will progress to the marginal gingiva and can also cause necrosis of the gingiva and spontaneous hemorrhage. If not occurred in HIV positive, it can progress rapidly to HIV periodontitis or necrotizing periodontitis. This is the example of NAC. You can see destruction of the IDP and already involved marginal gingiva. And not necessary that all area of the gingiva affected by NAC. Maybe this is still normal, see? And this is quite early ulceration, crater-like lesion at the IDP. Here and also here IDP and marginal gingiva. You can see down here ulceration with the bleeding already. And the patient normally will experience maybe metallic taste and hypersalivation. If you ask the history, maybe history of malaise, fatigue, not enough sleep, or like a lot of traveling before. The patient normally come with painful gums and maybe strange taste or metallic taste in the oral cavity. And if you can see this typical crater-like lesion, it's not so difficult to diagnose the disease as necrotizing ulcerative gingivitis. This is a quite mild symptom, just only punch out lesion or crater-like lesion on the IDP, here, here, and here, and also here, but normal still intact. So it depends, some case very severe generalized, some case just localized. Most important is that maybe early sign of HIV infection, or the patient also may have halitosis and regional lymphadenopathy at the same time. Once you diagnose as NAC, the most important is the local debridement, the superficial cleaning with can be with ultrasonic scaler, just superficially, because the patient is very painful along the gingiva. So try to do as gentle as possible and instruct the home care instruction, use soft toothbrush and give the mouthwash. The patient can be chlorhexidine mouthwash, 0.12% or 1% hydrogen peroxide, and prescribe antibiotics, metronidazole, clindamycin, or augmentin, and ask the patient to come back after 2 weeks. Normally, after 2 weeks, all the lesions disappear. But the most important is that you still need to correct predisposing factor, because some patients may have like underlying periodontitis or overhanging filling. So in that case, you need to correct all those. Otherwise, the patient may get necrotizing ulcerative gingivitis again. And actually, the prevalence of NAC is quite low in Thai patients, but for Caucasians, it's not low prevalence as in Thai patients, because in my experience, just only foreigners that getting NAC, but not so often. But once in a while, I see patients with NAC, but never in Thai patients yet. So all these are diseases in the first group, and maybe I missed a bit on oral ulcer secondary to chemotherapy, right? Why not in here? You can let you see later on. Uh, can we have a break for 5 minutes and then come back for Kaput test a little bit? Okay?
โอเคครับ
เห็นเลยค่ะอาจารย์มันเหมือนไม่ขึ้นนะคะ
ศึกษาได้ยินไหมคะ
ได้ยินค่ะ อาจารย์ค่ะ อันนี้ให้ใส่ชื่อเป็นเลข ID
ให้
หรื
เล
อว่า
ข
ชื่อเล่นห
เรา
รือ
ไม่
ว่า
เปิด
ชื่อ
อัน
จริง
นิ้ว
เหรอ
ได้
คะ?
ให้ใส่เลขรหัสประจำตัวเลยค่ะ
ค่ะ ขอบคุณค่ะ
อาจารย์ค่ะ ขอเลข
ตอนนี้
สมมุติอีกทีได้ไหมอะคะ?
เห็นแล้วใช่ไหมคะ? เดี๋ยวนะ แป๊บหนึ่ง เห็นหรือยังคะ?
มองไม่เห็นน่ะค่ะ
เอาใหม่ เห็นไหมคะ?
ไม่เห็นเลยค่ะ
เดี๋ยวนะคะแต่ได้ยินเสียงอาจารย์แล้วนะคะ
ได้ยินแล้วค่ะ
อาจารย์ค่ะ หนูขอรหัสอีกรอบหนึ่งได้ไหมคะ?
ค่ะ กำลังแชร์อยู่เนาะ
ค่
เห็นหรือยั
ะ
งคะ? เห็นหรือยังคะ?
ยังไม่
ไม่
เปิด เลยอะ
ยั
ค่ะ
งค่ะอาจารย์
แล้วตอนแรกหนูเห็นเหรอคะ? หนูเห็นไปทีหนึ่งใช่ไหม?
ตอนแรก
เห็น
เห็นค่ะ แต่ว่าหายไปแล้วอะค่ะ
หายไปแล้ว เดี๋ยวนะแป๊บหนึ่ง มันเกิดอะไรขึ้นกับเว็บ X เนี่ยแบบว่า เดี๋ยวนะคะ งงไปหมด ตอนนี้เห็นยังคะ?
ขึ้นแล้วค่ะอาจารย์
อ่า อ maybe no more ใช่ไหมคะอย่างนั้น Let's start okay okay next one นะคะ next one นะคะ ใครเอ่ยใครเอ่ยใครเอ่ยได้ที่1 2 3 ทีนี้ okay and any questions from the quiz any question
อาจารย์ค่ะข้อสอบของบทนี้เป็น choice หรือเปล่าคะหรือว่าเป็นข้อเขียนแล้วคะ
choice ค่ะ choice
ขอบคุณค่ะ
maybe I think we just only be a few students that would not give the correct answer so maybe you need to review a little bit but I'm quite happy that most of you can get the correct answer because you listen to my lecture and understand so because over 12 already so maybe we will discuss about it later on if you have any questions and we will meet again at 3 p.m. okay
ขอบคุณค่ะอาจารย์สวัสดีค่ะ
โอเคค่ะ